Hello, everyone. I'm Lorenzo Tavelli, and I'm a faculty at the Harvard School of Dental Medicine in Boston. And for me, it's really a great pleasure and honor having this opportunity to lecture for the AAP Hour. And I'm looking actually forward even more to interact with you after this presentation. So I think without further hesitation, I would like to start this very, very interesting topic, which is basically soft tissue augmentation at implant sites using both autogenous and non-autogenous grafts or graft substitutes. What is the rationale of doing soft tissue augmentation, or actually of doing something around dental implants? The rationale is that, I don't know, in your clinic, in your practice, but I see a lot of cases like that, or like this, in which we'll define this case better later on, but you can start to see that there is, let me use the term, there is less soft tissue than what is needed around dental implants. So a lot of times, these are actually aesthetic nightmare, sometimes probably not even possible to correct, while other times they are combined with peri-implant disease. But in order to better discuss this condition, and actually the topic of our lecture of peri-implant soft tissue augmentation, we have to define what is the peri-implant phenotype. And this is a concept that has been introduced by Dr. Velortis and co-worker with this commentary published in Journal of Periodontology. And I'm using these two pictures to compare and also highlight what are the similarities and the different concepts between teeth and dental implants. Because the concept of soft tissue phenotype in natural dentition was described in the 2017 World Workshop, and we can find as a reference the paper of Cortellini and Bisada, or overall the paper that summarized this consensus work for that topic from Jepsen and co-worker. So both for around teeth and dental implants, we can recognize the amount of keratinized tissue. Now, around teeth is called keratinized gingival width. Around dental implants is called keratinized mucosa width or keratinized tissue width. And then also, both teeth and implants, they have an horizontal dimension of the soft tissue in terms of thickness, which around teeth is called gingival thickness. Around dental implants is called mucosal thickness. Now, the difference is that dental implants, we can for dental implants, we can recognize also not just the horizontal thickness of the mucosa, but also the vertical thickness of the mucosa, which is called supracranial tissue height, and is the dimension that is going from the bone to the soft tissue margin, and this can be measured 360 degrees around the dental implant. Now, this is what has been described for the soft tissue phenotype around teeth and dental implants, but when I evaluate either healthy teeth, perfect teeth, or deformities of the soft tissue around teeth or dental implants, I like also to include this further evaluation that you're going to see in my slides. Around teeth, I want also to assess not just the soft tissue phenotype, but what is the level of the gingival margin, because if the gingival margin or soft tissue margin is not at the level of the cement-enamel junction, these teeth will have the so-called gingival recession, and the reference is the cement-enamel junction of the tooth itself. While for dental implants, when the level of the soft tissue margin is not in the ideal position, which the ideal position is not determined by the crown itself, but you have to see the cement-enamel junction of the contralateral homologous tooth. So if the soft tissue around the implants has the same level of the ideal position of the gingival margin, which is the cement-enamel junction of the contralateral homologous tooth, now I will say that that's the ideal position of the peri-implant soft tissue. While when this level is actually more apically positioned, we have a so-called peri-implant soft tissue dehiscence. Very briefly, I want to mention just because it's not the topic of today, that sometimes we have conditions in which before talking about how can I modify or increase the dimension of the peri-implant soft tissue phenotype, sometimes we have to do bone augmentation either at the time of implant placement or, like in this case, prior to implant placement for having an adequate so-called peri-implant bone phenotype or morphotype. But this is just to explain to you that it's not that, since this lecture is going to focus on soft tissue, it's not that we do not do bone augmentation, but the topic is just very, very extensive. And today, in this hour or so, I have to focus on soft tissue only. But when I need to do bone augmentation, I always do either prior to implant placement or at the time of implant placement. The soft tissue augmentation, either with autogenous graft or substitutes, comes later in a second moment. So we will focus today in this lecture on the soft tissue phenotype only, and in particular around dental implants. So the first question that I have for you is that, do we need keratinized mucosa for maintaining dental implants? Because this topic has been debated for, I would say, decades. But nowadays, I think overall, the most recent article, they seem to point towards the same direction. And we're going to discuss this. So here is the dimension of the keratinized mucosa. And as we'll see in my lecture, I like a lot to perform non-invasive ultrasonography around dental implants. And in this case, when I do the basically ultrasound scan at the midfacial aspect of my dental implants, this is the part of the crown that I can see. This is the abutment. Part of it is exposed to a cavity, but most of the abutment is covered by the peri-implant soft tissue. Here is the buccal bone. And if I have the buccal bone that you can see with this white line, I do not see the implants underneath. And this is the part that represents the soft tissue. And in particular, this is the keratinized mucosa. We're going to see more and more this scan, but as I mentioned to you, this is the first question I want to introduce. Do we need keratinized mucosa around dental implants? Now, these are the 4 points that I want to discuss, and then at the end, you will tell me if you agree with my way of thinking. Let's examine before the effect of keratinized mucosa on peri-implant health. And I want to start from this, I would say, very famous systematic review of my dear friend, Dr. Lin, that, by the way, he's the colleague that invited me for this lecture. So I want to thank him again for his kindness and his invitation. This systematic review, I would say, is the first of this period. It was published in 2013, that addressed this topic, and I would say probably started this debate whether we need or we didn't need, because previous papers before these were just basically reviews. They were not meta-analysis, and as you know, meta-analysis when not only you select in a systematic way certain articles, but also you analyze their data. So long story short, you can see all the parameters that were assessed. The authors demonstrated that implants having adequate amount of keratinized and attached mucosa, they were more likely to have less accumulation of plaque, less inflammation, less midfacial recession, and less attachment loss compared to implants without an adequate amount of keratinized mucosa. So this article concluded that based on the current evidence, it seems that a lack of adequate keratinized mucosa around dental implants was associated with worse peri-implant condition in terms of these parameters that we just mentioned. Another articles from Brazil, and actually from my dear friend André, wanted to investigate not just peri-implant health, but also other parameters like patient-reported discomfort. And they still divided the implants into groups, having keratinized mucosa less than 2 mm versus having at least 2 mm or more of keratinized mucosa. And they demonstrated that the implants with less than 2 mm of keratinized mucosa show an association for more discomfort during brushing, but also clinically they demonstrated more plaque accumulation and inflammation compared to the other group, which is the implants with more than 2 millimeters of keratinized mucosa. So here, for example, is a clinical exam, is a clinical case in which you see a very, very thin, maybe 0.5 millimeter band of keratinized tissue, but this is not enough for having this keratinized tissue attached. So when you move the probe with this motion from apically to the sulcus, you see that this soft tissue is not attached. It's very interesting that this group from Brazil, the paper from Dr. Souza, was a cross-sectional study. And then they follow the same patient cohort over time, and the study became longitudinal and was published later on by the same authors, in particular, first author is Dr. Perussolo, in which they analyzed the Fourier data from the same group. They basically demonstrate further the previous findings, in which still implants without an adequate amount of keratinized mucosa had worse clinical condition, as worse outcome in terms of patient reporting discomfort, but also they demonstrated that margin of loss was higher when implants didn't have or had a very narrow band of keratinized mucosa. So the author suggested that having 2 millimeters, at least 2 millimeters of keratinized mucosa, may have a protective effect on peri-implant tissue. Now, very quickly, this other article from Monk and Blasi demonstrated that all of these parameters that we previously discussed in terms of depth, suppuration, inflammatory index, and also patient reported discomfort during brushing, they're actually worse in a patient having a very narrow band of keratinized mucosa, and in particular, not in just patients that are coming frequently to the appointment of maintenance, but in the so-called erratic maintenance compliance, which I believe this observation is very relevant in our practice, because we don't have to assume that all the patients basically will come every 3, 4, or 6 months. So also here, it seems that having 2 millimeters or more of keratinized mucosa may be beneficial also in this case scenario. So from this article, we can further highlight that it seems that we need our implants to have a band of keratinized mucosa in order to have less plaque accumulation, to facilitate patient oral hygiene. And this results in less recession, less inflammation, and eventually less marginal loss around dental implants. Because it's also possible that these are consequence of patients that they can clean better when they have more keratinized mucosa, which is related to the vestibular depth that you have around your implants. And also because the keratin layer, it has been suggested that provides a function of mechanical stability and protection for the peri-implant tissues. So it seems that there is a role of the keratinized mucosa on peri-implant health and also the comfort that the patient has, and these two factors are correlated. But also having keratinized mucosa around dental implants is very important for the aesthetics and the stability of the soft tissue around the implants over time. In this study that they performed at the Tufts University in Boston, with patient questions, they demonstrated that patients are actually able to identify when they have implants without keratinized mucosa, and these implants were actually rated having less aesthetic outcomes compared to implants with keratinized mucosa. So you have to think that it's not just us, a professional, we can say, okay, this implant does not have enough keratinized mucosa. Patients are able to assess this as well. And also we perform this study in which we analyze clinically and ultrasonographically, not just the prevalence, but the risk indicators associated with implant aesthetic complication, or like I prefer to call this condition, peri-implant soft tissue dehiscence or deficiency. These are just patients with dental implants in the anterior area. And we basically, long story short, we demonstrated that the risk indicators for this condition is when you have a lot of dental implants close to each other, so not a single implant with 2 adjacent teeth, and also the more years the implant is in function. But, and here is a factor that I want to highlight, absence or very limited keratinized mucosa. So one more time, the keratinized mucosa plays also a role on the aesthetics, because if I place an implant in the anterior area and I only have alveolar mucosa, it's very likely that maybe not right away, but over time, my implant develops an apical shift compared to the DL level, and I will have a peri-implant soft tissue dehiscence. Now, since we're talking about this paper, I want to also show the other factor associated with this condition, like very thin tissues or reduced mucosal thickness, and we're going to talk very soon about this factor, but also having buccal bone dehiscence, that in particular, our model revealed that each millimeter of buccal bone that your implant lose over time increase the odds of having implant complication by a factor of 41%. Here is a clinical example that was treated with connective tissue graft. You can see that after a few years, we perform a soft tissue plastic, and these are the results after 3 years. So keratinized mucosa not only is important for peri-implant health, providing also better comfort for patients during brushing, for the aesthetic and the stability of the soft tissue, but also when we talk about implant that is diseased, particularly having peri-implant mucositis or peri-implantitis, when you actually have to perform an intervention that is either non-surgical or surgical, and this intervention, of course, is aimed at re-establish peri-implant health, having a certain amount of keratinized mucosa is a positive factor for your treatment outcome. So because of all of these factors, I believe there is enough evidence to conclude that keratinized mucosa is beneficial around dental implants. Now, I went very quick on this cutoff value of 2 millimeters. Is a value that has been suggested actually in natural dentition from Lang et al. So I cannot completely agree on this value, 2 millimeters. Let me just say that I agree that we need a certain amount of keratinized and attached mucosa around dental implants. Maybe it can be 2.5 millimeters, maybe it can be 2.3, but overall we need a certain amount of keratinized mucosa, which is also attached. So I will not be okay in having a case like this, or like this, or look even at these deformities around a dental implant that, of course, a patient cannot clean in this case scenario. And these implants, if we do not perform something, sooner or later, they will have a disease. The second question that I have, and I hope that we all agree at that point that we need keratinized and attached mucosa around dental implants. The second question that I have is that, do we need to have a certain mucosal thickness around dental implants? Is that important? So here is a case of an implant soft tissue dehiscence. You can see that the reference, in this case, my implant number 7, has the soft tissue margin position in a higher level of the reference that would be the lateral number 10, but also you can see that it's not aesthetically pleasant having the lateral, which is longer than the center. And we don't know the exact etiology of this case. I can speculate that the implant was positioned to buccal, so the patients also, the implant lost buccal bone, but the tissue is very, very thin. So you can see this example, in blue, I color the soft tissue. Here are their cases, but what I want to highlight first is that the cause of mucosal thickness has been, let's say, the importance of mucosal thickness in our dental implants is a relatively recent concept. Before was more a prosthetic consideration. Previous work basically highlight that when the soft tissue is too thin, it's very likely to have a discoloration of the soft tissue because you have titanium abutment or titanium implants, if you have some buccal bone dehiscence, underneath the soft tissue. So previously it has been suggested, and also here we use this conventional number 2 millimeters, even though I don't agree too much when a number is just purely suggested like this and doesn't come from statistics. But let's say that it has been suggested that having at least 2 millimeters of soft tissue thickness in a horizontal way, okay, is important for avoiding your dental implants to have a dark color and an unpleasant aesthetic outcome. So this was from more prosthetic point of view. However, we started to understand that mucosal thickness is also important for other related factors. I showed you before the study that I conducted with several of my coworkers when I was at the University of Michigan, in which having a thin mucosa was also shown to be associated with implant aesthetic complications. So when the soft tissue is too thin, it's very likely to have clinical scenarios like this. And how do you assess the thickness of the tissue? Well, of course, sometimes it's relatively obvious by observing that the soft tissue is very thin, but if you want to actually quantify, if you want to see better, of course, you have to do some measurements. Back in the day, in clinical research, patient was anesthetized and a needle was inserted through the soft tissue, which I believe nowadays is a little more challenging doing that, because unless you're actually performing a surgery, patients are probably not okay in allowing you to have this procedure. What I like to do, as I mentioned to you before, is performing ultrasound using dental ultrasonography. And was lucky that I was introduced to this technology when I was a resident at University of Michigan, and this technology was brought by my faculties and mentors, Dr. Chan and Dr. Kripkans. And since then, I've been using this technology a lot, and I see all of its advantage and potential for application even more and more in our field of periodontology and implantology. In particular, you can see that this patient has 2 implants because he had congenitally missing lateral incisors. I highlighted for you the ultrasound scan. In particular, in yellow, you can see where is the crown around both implants. You can see where is the portion of the abutment. And in the implant that actually has the exposure of the abutment to the oral cavity, you can see at the beginning there are some threads exposed above the bone. So this is actually the implant fixture. And then I can see the buccal bone. So if you don't believe me in this, in my way of coloring the ultrasound scan, and at the beginning, of course, is something that is not too much immediate to recognize and be able to read correctly the ultrasound scan. So here I want to show you the surgical picture because this case was treated later on, in which there is a portion which is the abutment exposed to the oral cavity, but some of the abutment is actually inside underneath the flap. And then there is the red portion, which is a few threads of the implant that are exposed, are not covered by the buccal bone. And then in yellow, I color for you the buccal bone. So here is basically what I can see with the ultrasound without opening a flap. And going back to the ultrasound scan, in blue I color the soft tissue component of the implant number 7, and in purple of the implant number 10. I apologize, I forgot to orient the ultrasound of this picture with the crown down in the lower part of the screen. In that case, they were oriented the opposite. But you can see my goal in this slide is to show you that the implant that has actually the aesthetic complication has much thinner tissue. And of course, with this technology, you can quantify it, but has thinner tissue compared to the implant that has the soft tissue margin located in a correct level. So it seems, I mean, it's just a case, I will show you later on some literature, but it seems that having enough thickness of the soft tissue can help your dental implants in having stable soft tissue margin over time. So for your curiosity, this is the same case that we treated like this. We open a split thickness coronal advanced flap, and we use this autogenous graft, which is still a free gingival graft that is in the process, because I'm removing the epithelium, so it's a process of becoming de-epithelialized connective tissue graft. That's my favorite way of harvesting soft tissue on dental implants. Then the graft was secured with several simple interruptive sutures. Then the flap was advanced, and these are the results after 3 years. I'm showing this case because I can show you also the ultrasound scan. You can see how much in blue I color the dimension of the soft tissue, so you can see how much we increase this aspect. That for me means stability over time. Because why do we need to perform soft tissue augmentation or this in this particular cases, or the next cases I'm going to show you? Why do I have to perform mucosal thickness augmentation? Because thickness is vital. And why is vital? So I want to use this concept that has been validated around teeth in natural dentition. We recently published in Journal of Clinical Periodontology this article that I had the pleasure to work on with a lot of friends, mentors, and colleagues. In particular, that was a great effort from my dear friend, Dr. Barucci, in which we were able to call back several patients, 83 subjects, that previously were enrolled in a randomized clinical trial that were performed at the University of Michigan. And this patient had follow-up more than 10 years. Some of these patients had 13, 15, 17. But our goal was to see in a control population, not in just patients that randomly receive a procedure. So we had all the data at baseline and either 6 months or 1 year. We wanted to see in the same cohort of patients that participate in these clinical trials, where root coverage was performed, what were the factors that were associated with the long-term stability of the outcome, which has recently become a topic of great interest in the scientific community. And also for patients that often ask me, is this treatment going to last over time? So, long story short, we demonstrated that the long-term outcome of recovery procedures are heavily affected by per-implant soft tissue phenotype modification. In other terms, you want to perform a procedure, regardless of which graft you're going to use, which technique or flap you're going to use, you want that your procedure is able to increase the thickness of the gingiva in a way that gingival thickness at 6 months is at least 1.466, let's say 1.5 if you want to round this number. Because if you achieve this dimension of gingival thickness, we calculate from the statistical model that is the thickness associated with the stability of the soft tissue margin over time. That's why before I was telling you, I don't like when we just use 2 millimeter here, 2 millimeter there. It might be probably close to the correct actual number, but it's just a speculation or something that has been too quickly used as a cutoff number. I like to use these in natural dentition, let's say 1.5 millimeter, because we actually demonstrated this in this paper. Now I know that these are teeth and they're not dental implants. And I believe that teeth and implants have a lot of similarities, but also different points. So I'm not going to use the same number, 1.466, around dental implants in terms of the thickness that I want to obtain with my intervention. But I show you this concept because overall, I believe that we can use the same hypothesis, the same concept around dental implants, that we want to increase the thickness at implant sites when the soft tissue thickness at the beginning is very limited. And we want to obtain a number. Now, around dental implants, I speculate is probably more than 2 millimeter, or definitely is more than 1.5. We want to obtain a certain number of gingival thickness that also around dental implants is going to provide the stability of the soft tissue over time. But of course, we need more and more studies in order to prove that we have the same or a similar number around dental implants. But let's start to see some cases and more cases together. I had this patient in residency that presented with this exposure of the abutment and just a very slight complaining of discomfort during brushing. So should I treat or not this case? I always joke saying that if you see a case in my slides, it probably means that I treated this case. But let's look together, and I mean, by the way, yes, I treated this case, but let's look together why I treated this case. Is in the posterior mandible, so it's not an aesthetic case. Even the patient gives me her biggest smile, I cannot see the metal. So I look at the phenotype. If I had here a very good band, I don't know, 2, 3, even 4 millimeter of keratinized tissue, with this band of keratinized tissue being attached, I will not be concerned at all of having a small exposure of the abutment. So my concern here is that I have to evaluate the phenotype. And the phenotype in this case is thin. I don't have keratinized mucosa, or it's just 0.5 millimeter. The mucosa is not attached, and the soft tissue seems thin. Well, I know that it was thin because I performed several measurements and assessment. in particular, look how is the progression without any treatment when I saw the patient after 1 month. And only because the phenotype was thin. So here I took a picture with a probe. These are phenotype probes that can give you a very quick estimation of the thickness of the tissue based on the color. If you see the white, the green, or the blue, they cannot give you the exact number, but overall they can show you in a very fast way if the tissue is thin or thick. You can use even a periodontal probe. But here I want to show you how the tissue is so thin and it starts to bleed when I just introduce very slightly my probe. So the patient didn't want at the beginning to have the treatment. And when I saw the patient after 1 month, I tried to convince her even more that the treatment was actually necessary, not for the aesthetic reason, but for having a better soft tissue seal around this dental implant. And here is how I saw the patient at 3 months without any intervention, because from the picture in the middle, 1 month to 3 months, basically the patient was convinced to do the treatment. It's just we didn't find any opening, any date that was working for both the patient and I. So at 3 months, the patient showed the surgical appointment in this way, in this manner. And all of this happened. It doesn't happen around all the dental implants, but this progression, this apical progressive shift of the soft tissue happened because the peri-implant soft tissue phenotype was very thick. And when I say peri-implant soft tissue phenotype, one more time, I include the keratinized mucosa and the soft tissue, the mucosal thickness. So long story short, also in this case, we perform a connective tissue graft that was sutured to the periosteum, and then we advance the coronal advanced flap. These are the 6 months result. But as I mentioned, and as I showed you before, how it's important to assess the treatment outcome of our augmentation. In particular, I want to assess thickness. How do I know that my treatment was successful in giving me an increase mucosal thickness or peri-implant soft tissue phenotype? Of course, I can see the picture before and after. We can see the ridge that from concave became convex. And actually, you can assess the volumetric changes with 3D digital scan. But the digital scan is just going to tell me the variation, which I assume happen only in the soft tissue, not in the bone. But it's not telling me right now at 6 months how is thick, how is the thickness of my soft tissue. So one more time, I use the ultrasound, and this my ultrasound scan, and the soft tissue I color in pink. And since I'm using ultrasound, let me say that it seems we're able to make the soft tissue pregnant just in 6 months compared to the soft tissue before, that you can see is a very, very tiny band of 0.6 or 0.8 millimeter. Right now, in the middle portion of the abutment, we have almost 2.5 millimeter of soft tissue thickness. Therefore, what does it mean, this to me? It means that it's very likely that this patient will have stable outcome over time. 1 year, 2 years, 3 years. And this is the scan taken at 3 years. Everything from a soft tissue point of view is stable. And I was curious actually to do the superimposition of the digital impression taken with an intraoral scan, that basically where you see green means that nothing changed. Of course, we didn't do an intervention around those areas. But where you see in blue, and we can also quantify these, of course, where you see in blue, it means is how much volume we gain between baseline and 1 year. So from baseline to 1 year, we gain, I would say, substantial volume. But very interesting, when I do 1 year versus 3 years, everything stayed the same, meaning that I didn't have any changes. Soft tissue remained the same in terms of thickness and in terms of level. Now, I hope that at this point I convince you that we need to have a certain band of keratinized mucosa and a certain amount of mucosal thickness around dental implants. And here is another scientific paper that I want to briefly discuss with you, because we saw together so much references supporting that we need a certain amount of soft tissue around dental implants. With this paper, we wanted actually to perform a systematic review and net meta-analysis comparing different grafts together, but also different approaches. But the main focus question was, what are actually the real benefits of performing soft tissue augmentation on dental implants? And we had bilaminar techniques in which whatever is the graft that you use, autogenous graft, collagen matrix, acerbic matrix, the graft is completely submerged during the procedure and hopefully also during the healing by the flap. So the graft is going to heal by primary intention. Versus we also had several articles that perform soft tissue augmentation with a so-called apically positioned flap-based techniques that are techniques in which the flap, which is usually just a veil of mucosa, is apically repositioned, and the graft, usually autogenous with gingival graft from the palate with both connective tissue and epithelium on top, is positioned around the dental implants, and these procedures are usually performed in non-aesthetic areas to gain keratinized mucosa. And we had several groups performing this same procedure with acerbic matrix, collagen matrix, connective tissue graft, or even flap alone. But long story short, I put this article in the presentation because in this article, we investigate the impact of soft tissue phenotype modification either with bilaminar techniques or apically positioned flap-based approach on peri-implant health. So we demonstrated that when you do apically positioned flap-based technique, your implants overall result in less plaque accumulation compared to before, less recession, and lower plaque accumulation. We didn't have enough article exploring marginal levels, but this is something we're able to investigate for bilaminar techniques, where basically augmenting soft tissue thickness, and we had articles mainly using autogenous connective tissue graft or xenogenic collagen matrix, which is a graft substitute from animal origin, in which you put the collagen matrix underneath the flap as a substitute of autogenous graft harvested on the palate. These two groups show that doing an augmentation for augmenting mucosal thickness resulted in more stable marginal levels compared to non-augmented sites. In other terms, if I place two implants, let's say in both laterals on a patient with congenitally missing laterals, and the soft tissue is very thin, if I perform augmentation only on one side, this side will have more chance to maintain stable marginal levels over time compared to the side that didn't receive any augmentation. So at this point, I think that we all agree that the answer for this question is yes, and the answer for this question is also yes. So very briefly, a case I did a long time ago in which this patient was referred to me because she had discomfort in this area, and overall she was not satisfied of her dental implants that overall were not surrounded by keratinized mucosa. The mucosa was not attached, and I believe that for this area, performing an apically positioned flap with an autogenous free gingival graft is very effective. Now, back in the days, you can see that my graft was, I would say, relatively big. So overall, the treatment worked. I got lucky and I covered also either completely or partially the abutment. I didn't increase the pocket depth, and I reestablished a condition of peri-implant health. However, you can imagine that the patient had significant morbidity due to this dimension of the graft. So if it was so simple to increase keratinized mucosa and the mucosal thickness, we'll just do free gingival graft for all of our cases. But aside from the lower aesthetic outcome of free gingival graft, you can see this color that is different from the adjacent soft tissue. It tends to be more pink because it retains the characteristic of the palate. It's not so simple to say we just do this procedure because there are several limitations. One of these limitations includes that you need to harvest a significant amount of soft tissue from the palate, especially the case that I showed you. And this can lead to several intraoperative and postoperative complications, including injuries to the palate, greater palatine artery, and most of all, what your patient will tell you is that significant postoperative morbidity. Recently published this review in Periodontology 2000, in which we focus on the wound healing dynamics, morbidity, and complication of soft tissue palatal harvesting. So let me go a little bit fast on this point, saying that what can we do to obtain the same increasing keratinized mucosa without harvesting from the palate, or without provoking so much pain or reducing the risk of complication? Now, first of all, compared to the case of before, we can do the same procedure, apically position flap plus free gingival graft, but reducing the height of free gingival graft. Okay, compared to before, is probably half of this height, and several papers demonstrated that the height, more than actually the width, together with the thickness, of course, is related of the graft, is related to patient postoperative morbidity. In other terms, I try to reduce this dimension, the height of my graft, and I position all of my graft this time on the periosteum in order to minimize graft shrinkage. Because if you position this graft a little bit on the implant surface, a little bit on the abutment, especially if the graft is small, probably the graft in that area will not survive. So one possibility to obtain this, to increase keratinized mucosa, is to reduce the dimension of your free gingival graft. Now here you can see that is probably, I probably gain less amount of keratinized mucosa compared to the case of before, but it's probably what these two implants need. They don't need anything different. But we also have other solutions. In particular, here is an implant that I recently placed myself. And after performing also some bone augmentation, you can see that the implant resulted in very limited, like often occurs after bone augmentation, at the time of implant placement, the amount of keratinized mucosa is limited at the buccal aspect. So, of course, you can do the same approach, harvesting a big free gingival graft, but aside from the risk of complication and patient morbidity, can we do something different while obtaining the same outcome? I performed the so-called strip gingival graft, in which a very small strip, 2 millimeter, maybe 2.5 millimeter in height only, is harvested either from the palate, or sometimes I do from the buccal aspect, the contralateral aspect compared to the implant that I'm treating. Sometimes patients have maybe even 4 or 5 millimeter on the maxilla or on the mandible. And then this strip gingival graft is combined with axanogenic collagen matrix. This is the 4th generation of collagen matrix, and is actually probably the only biomaterials nowadays that we know we can leave exposed with a healing by secondary intention. So you can see that I put my strip apically, because in this way I have living keratinocytes and fibroblasts that will migrate and colonize the collagen matrix at the early wound healing time points. And in this way I can reduce the amount of soft tissue that I have to harvest, reducing complication and patient morbidity. These are the outcome after 3 weeks. And the ultrasound scan is highlighting the keratinized mucosa at the early time points, and also soft tissue thickness will also gain. And this is when I see the patient at 3 months. He was waiting a little bit before having the crown, and nowadays the patient, now he has the crown. I didn't take the final picture and I didn't put in this presentation. So here were some methods, either big autogenous graft, I don't do anymore, for increasing keratinized mucosa. Either I go for a very, very small autogenous graft, or I do this combined technique, the strip gingival graft, in which I use a very, very small amount of graft for having in that area a barrier rich with keratinocytes and fibroblasts that can colonize my collagen matrix. Mucosal thickness augmentation can be performed at different time points. Can be performed at the time of implant placement. This is a recent case that I did a few weeks ago, that I wanted to open 2 verticals here to secure my connective tissue graft around after, or I would say at the same time of implant placement, to correct this discrepancy in the buccal ridge. Okay, and this is how I close. I will probably show you the follow-up during our session with question and answer. And similarly, another case that I did recently is that after implant placement, in that case in the mandible, we decided to open the flap like this in order to introduce this a second generation oxygenic collagen matrix in which this biomaterial was inserted underneath the flap that was released. You can see that in this area between the molar and the premolar, we open in this way because also these two teeth had a small recession. We deepitalize the papilla between the premolar and the molar, and then we secure the membrane with simple interrupted suture. Then I perform a small incision at the flap in order to have a better adaptation around the healing abutment. And that was the final picture that also in this case, in our discussion, I will show you the follow-up of at least a few weeks or a few months. So these are examples of mucosal augmentation can be done at the time of implant placement, especially if you don't need to do bone augmentation. I know that some colleagues, they like to do at the same time bone augmentation, soft tissue augmentation. My preference is, in case if I have to do bone augmentation, I postpone my soft tissue augmentation if needed. But of course, if you do not need to do bone augmentation at the time of implant placement, you can do as well soft tissue augmentation, either with autogenous graft or substitute. However, I like to do soft tissue augmentation very often in combination of immediate implant therapy, because when you extract a tooth, it's more likely, and we know from the literature, that we're going to have a significant, even if we do bone augmentation at the same time of implant placement, we're going to have a significant resorption of the alveolar ridge. So doing at the same time soft tissue augmentation can help in maintaining, I will not say the bone, but the overall contouring of the ridge. So these are tooth that was considered non-restorable for a decay at the level of the root. So we extract the tooth, and with a guide, we plan the immediate implant placement based, of course, on the occlusion of the patient and several other parameters. Here I go relatively quick. So what I want to show you is that after I prepare also a provisional restoration, which is called the socket seal abutment. I grafted the socket in order to try to maintain as much as possible the resorption, the dimension of the ridge, because we know we're going to have some resorption, but if we put some bone graft around the dental implant, it's very likely that we can minimize this phenomenon. And then at this point, I want to do soft tissue augmentation for maintaining the overall volume of the soft tissue, but also because I showed you before evidence that if I increase soft tissue thickness, I have more chance to maintain the stability of the soft tissue over time together with the stability of marginal bone levels. So in this case, you can see, let me go back to the picture, that you can see that we started with a good amount of keratinized mucosa. So can I perform augmentation with autogenous connective tissue graft? Of course we can, but after a surgery, after extraction, after patient having some, for sure the patient will have some morbidity related to our procedure, I want it to be less invasive and using, instead of an autogenous graft, which of course will work as well in this case, I wanted to use this graft substitute. And I had to just open the papilla between the premolar and the molar, which still was a little bit fragile because of the extraction. So I just completed the opening of this papilla. I inserted the biomaterials, and then I give 2 or 3, even more, maybe simple interrupted sutures. You can see these are the X-ray, and you can see the progression of the healing: 2 weeks, 3 months, and 6 months. Now with the buccal view, you can see how we're able to maintain the soft tissue at the same level. Actually, I think probably we also, or maybe it's the crown, but we also either advance a little bit or maintain the soft tissue at the same level. And the 3D scan is showing us that there are some areas, especially the more corona, in which maybe we lost a little bit of volume, but there are also some areas in which overall we gain volume. So I like to perform soft tissue augmentation probably almost around all of my all of my implants that I placed at the same time of a tooth extraction. Another possibility of doing soft tissue augmentation is before loading, can be a second stage, or can be even later on, but before putting basically the temporary or definitive crown. Here is a case that was a courtesy of my dear friend, Dr. Barucci. I supervised this case when we were working together in Michigan. He previously placed this implant, and we saw some deficiency in the thickness and overall in the volume. And also we thought that we could do also some gingival phenotype modification on the adjacent premolars. In this case, we use a human cell of the matrix after I have been rehydrated according to the characteristic of the material and the suggestion of the producer. In this case, we perform a tunnel from the sulcus of these premolars and the sulcus of the implant and also the canine. But also we did a distal cut similar to the Vista technique firstly described by Professor Zadet. So we did a combination approach in order to be able to, with some suture and also with tunneling instruments, to be able to introduce this asserted matrix, which is relatively easy to introduce in a tunnel flap. And then we stabilize around the implants and the adjacent teeth. I have just a picture of early healing. I don't remember if 6 to 8 weeks, but overall, it seems that in the short term, of course, we have to see and wait for longer healing, we're able to do some soft tissue augmentation, both at the implant side and at the adjacent teeth. But what happens when I already have implants with crown? Basically, can I do soft tissue mucosal thickness augmentation around loaded dental implants? Of course I can, but what is the rationale of doing soft tissue at this point? These are more likely implants that you didn't place yourself. Otherwise, if you know that the soft tissue is thin, you know that you should perform soft tissue before sending the patient to the final crown. But it's more likely that are cases that they send you patients because they have an aesthetic complication. So the soft tissue was too thin. Usually implants are also malpositioned, misplaced. You can see these two implants are too buccal. So, and definitely these cases, all the cases of peri-implant soft tissue dehiscencies, all cases need at the same time during the treatment, not only the coronal advancement of the soft tissue in order to correct the aesthetic complication, but they also need some soft tissue augmentation or soft tissue phenotype modification, where we have to increase mainly the thickness. So this was a case of a patient that, other than these two dental implants, she was periodontally and systemically healthy. She told me that she had a car accident around 20 years before, if I remember correctly. And it was probably one of the few dental treatments that she received. She was a little bit anxious about the dentist, but she was determined, after many, many years in which this complication occurred, she was determined in see whether whether it was possible to fix this complication or not. Here we have different challenges. First challenge that we have to fix this complication is that it's not one implant. There are two implants and they're close to each other. So usually I'm expecting the bone level interproximally to be lower and the papilla to be lower compared to usually implants that they have two adjacent teeth. Then the second problem is that the implants are very buccally positioned. There is this depression within the soft tissue. So implant positioning may be a problem for our treatment. But also maybe this picture was taken with an angle, so it's not super clear. But let me tell you that the papilla between the two implants was relatively flat. Maybe not completely flat, but in order to do this treatment, in order to improve the aesthetic, I know I have to do something also in terms of papilla augmentation. And the last problem that I forgot to mention, one of the main motivations that was driven the patient for having a treatment with me was that in a few months, probably 6-7 months later, she would have had the wedding of her son. So this is good and bad. I mean, it puts you a lot of pressure on you, but at the same time, when I had to tell the patient that for doing this case, I need to remove the crowns and she need to stay for some period with just a provisional crown, if there is such a strong motivation, usually patient tends to listen to you. Because otherwise, let me tell you, this case will not work without replacing this crown or without leaving the patient for a period of time without the implant supported prosthesis. So remove the crown, the abutment, and for these particular implants, we found the cover screw. And this is already important because it's giving me a very, compared to before, it's giving me a very wide recipient bed, very wide papillae between the implants on the right and the lateral incisor, the implants on the left and the lateral incisor, and also wide papilla between the two implants. Again, you can see that the problem is that the implants are placed to buccal, so I'm not really expecting to have buccal bone. Maybe these patients and these implants, maybe they had buccal bone when they placed the implants. I assume either there was no buccal bone or was so thin that got resolved over time. And the soft tissue is very thin, and the keratinized mucosa is present, but is very, very limited. So I perform a trapezoidal coronal advance flap. That in that case, I decide to perform this flap design because I have such a wide, after I remove the crown, such a wide recipient bed. So I believe this flap design is giving me the possibility of repositioning the flap without too many problems, and also give me visibility. So here is how I open split thickness coronal advance flap. And when I do that, I don't want to remove the soft tissue, healthy soft tissue, which is adherent to the implant fixture. This soft tissue, which is adherent to the implant fixture, is not the soft granulation tissue you have to remove when you do treatment of periimplantitis. So this is just healthy soft tissue that is there just because buccal bone got resolved. And there is, I cannot say attachment because it's not perpendicular. We use attachment just for teeth, but it's adherent. And if I leave it there, I have more chance that my graft is gonna survive, and I'm gonna have probably less shrinkage of my graft because I have more blood supply, and I don't know what are the outcomes if I try to suture my graft directly on the implant surface of the titanium. So I want to leave this area, and how do? I just perform a split thickness elevation on my flap. I already knew, because I took an ultrasound scan before, that my implants were outside of the buccal bone and without buccal bone. So this I already knew. Then I perform a free gingival graft on the palate, and this is the graft after I remove the epithelium. And then I de-epithelize the area coronal to my initial 2 or 3 horizontal incision, because this is where my flap will be advanced. So if I want to advance my flap in this area, I have to remove the epithelium. I stabilize my autogenous graft with multiple sutures. These are 7-0 resorbable PGA sutures. So that's why it's very important to open split thickness, because then I can stabilize my graft better to the epithelialized papilla here, to the periosteum, apically in the middle or apically in the sides. Then here, the curious things about this case is that I was actually planning to do at the same time papilla augmentation, putting one small graft between the 2 implants, but I started to close the flap and I forgot. Now I think it's probably not the best idea after probably 1 hour, 1 hour and a half of the surgery or so, tell the patient that you need to re-anesthetize the palate and extending and harvesting a little bit more. So in that moment, I just thought, okay, let me finalize the case like this, let me submerge everything, and let me think later on what I should do for papilla augmentation, because when you advance and submerge the implant after soft tissue augmentation, you know that there is another procedure in which maybe you can do a small retouch if needed. So this is the occlusal view, and exactly as I closed, this is how I saw my flap after 2 weeks. Then I waited for a longer follow-up. These are 3 months, actually I think 4 months. And now I have to plan my reopening. You can say second stage, not really second stage, but reopening. So you can see that what I want to do, I want to try to gain some papilla, but it's a little more difficult because then I have also to deliver the temporary crowns. But at the same time, I want to move some keratinized tissue to the buccal aspect, because by doing like this with my flap, I basically advance the alveolar mucosa that right now is too much close to the midline. So I thought that if I do this flap design, I stay away from the adjacent papillae, and I do everything split thickness, except in the small area in which I have to identify the implant cover screw, then I can gain keratinized mucosa. And furthermore, if I create a small pedicle, a small area even deeper, in you can see this area that I wrote deepitalized and then split. If I create this small that we can call rotated papilla or pedicle, if I deepitalize, I can do basically I can do a papilla technique or roll technique and try to see if I can increase this dimension of the soft tissue at the area of the peri-implant papilla. So this is what I did with a round bore before doing my elevation. And then this part that is deepitalized, I was planning to flip on itself and holding with some sutures. Here is how I perform my elevation. And in this picture, there is everything that I've explained to you in this lecture about soft tissue augmentation. Before and after, now I believe we increase the same thickness also around the implants, the right implants, the implant you see on the left part of your screen. Maybe my split thickness at this second surgery was a little bit in a way that I left more thickness in the flap, but no problem, because I have all of this thickness that later on I'm going to suture back my flap. But if you really pay attention to this, basically before I was seeing the implants, and right now I'm not seeing the implants anymore because I have enough soft tissue thickness which is adherent to the implant surface. Therefore, I just complete the case, rolling the papilla between the two implants and delivering temporary crowns. And I work on this case from the beginning to the end with Dr. Mendoza and Dr. Meneghetti. And basically, these are the results after 1 year. Now, it's probably not perfect. I could have done maybe better papilla augmentation if I would have done at the same time of the surgery. But overall, I was very satisfied. The patient was very satisfied. But most of all, I know that by performing this soft tissue augmentation and by increasing of so much this the amount of the mucosa, keratinized mucosa width, horizontal mucosal thickness, you can see just from the picture the contour how it's different. I'm sure that this is going to be stable over time, because I don't want to ask the patient to go through significant discomfort for the therapy without maintaining this outcome over time, because I'm asking the patient to stay for some period without a crown. This patient went through 2 surgeries. I mean, the second one was relatively easy, but there was significant patient discomfort. So when I ask the patient to undergo this treatment, I want to know that this treatment is basically going to have very, very good chances to stay stable over time. And I promise that's the last ultrasound I'm going to show you. And I know right now you already know how to read it very well. But bottom line, where I put the C is the crown, A is the abutment, I is the implant threads, because these implants, both at baseline and 1 year, they do not have buccal bone. But what has changed around both implants, together with other things, of course, is the dimension of the ST, which is the soft tissue, that when I actually go for doing these measurements based on where you measure, let's say that I measure around 1.5 millimeter below the soft tissue margin, I increase the horizontal soft tissue thickness of approximately 2 millimeter. So having 2.5, 2.6 millimeter after 6 months, or in this case 1 year, is what is my warranty, is what make me feel, make me sleep better overnight. Because this case, I'm very confident is going to stay like this in the long term. And at the end, why are we doing these cases? We're not doing for having a nice case to show you right now in the lecture, not for showing the ultrasound, the thickness before, after, but we do this for providing a service to the patient. And this patient at the end was so happy. Several months later, she finished the treatment with me. She moved to another state. I moved to another state. She sent me a very nice email attaching the picture of the wedding of the son. She was able to go. She enjoyed the wedding, and she had amazing memories and amazing pictures, because at the end, why are we doing soft tissue augmentation and dental implants, either with autogenous graft or substitutes? Is for providing a better service for the patient, for patient to be satisfied for their dental implants, for providing better comfort during brushing, better aesthetics, and to have more chances of maintaining peri-implant health in the long term. And with this, I want to thank you for your attention. You can see in the screen different ways to contact me. If you have any question, if you want to discuss some cases that you might have, if you want actually some of the paper I mentioned in the lecture as well, you can contact me through social media, or you can see my email. I'm looking forward to have this follow-up discussion with you in a few weeks. But meanwhile, let me thank you, all of you, for your attention. And let me thank all the members of this AAP Education Committee. In particular, I want to thank Dr. Lim for the invitation. Looking forward to have this discussion with all of you. Thank you very much for your attention. Bye-bye.